Hello, welcome everyone. My name's Jo Miller and I'm the Global Health Facilitator here at the University of Oxford, and I support global health research across all the divisions. Welcome today to the Health Systems Impacts Forum as we explore connections and topics that people are researching in Oxford around climate and health. There's a lot of people who've registered today from different divisions. From the overseas units, we have people who've registered from Kenya, from Vietnam, from Indonesia and Thailand. We have a range of attendees from students to associate professors, senior researchers, postdocs, public health doctors, registrars, group leaders. There's a lovely broad range of people coming today. From people from the Leverhulme Centre for Demographic Science. We have people from the Said Business School, Oxford in Berlin. We have people from the Big Data Institute, Nuffield Department of Medicine, Surgery, Population Health. So really looking forward to hearing the discussions that go on today. Just to let you know that the panelist session will and the convening session at the end will be recorded, and these will be shared after the session. The breakout room discussions will not be recorded though, other than with pen and paper by some rapporteurs who can help highlight some of the key discussion points that are covered. If there are any technical questions, please contact Tristram Walsh or myself via AirMeet messages, or there's a little purple button with a question mark on the bottom right hand corner of your screen where you can get help from the AirMeet staff themselves all together. I'm now going to pass over to Jim, who's going to open the session. Thank you.
Thank you, Jo, and good morning, everyone. Welcome to the second of these seminars and workshops in the Global Health, Climate and Health theme. My name's Jim Hall. I'm Professor of Climate and Environmental Risks in the Environmental Change Institute, and I'm also convener of the Oxford Networks for the Environment, ONE. ONE seeks to join up and facilitate and strengthen research on the environment and energy across the University of Oxford. There are 5 networks in climate, energy, water, food, and biodiversity. And the networks aim to both provide a coherent external-facing shop window, if you like, to the enormous diversity of research going on in those topics across the university, and also to facilitate interaction, collaboration within the university, in particular in relation to interdisciplinary challenges and large research opportunities. Health is clearly a cross-cutting theme across those broad areas of the environment and energy. And so it was with that kind of cross-cutting understanding in mind that the initiative that Jo is facilitating was brought into existence to do some more information gathering and networking around all of the many interactions between climate and health. And in part, that's because we see a growing demand for that, including from funders, and specifically from the Wellcome Trust has identified climate and health as being one of their main research themes going forward. Wellcome is a large funder within the university, and so we need to be positioning ourselves in relation to the changing thematic structure that Wellcome has adopted. And I think we're very well positioned in relation to that climate and health theme. And these workshop seminars are here to facilitate that, really with a couple of things in mind. The first is literally getting to know each other. There's such a diversity of research going on, and in particular in the health field, I'd say that from someone who works in the environment, I feel as though I have only a very limited picture of the incredible amount of relevant research going on in health, and that's incredibly rich because it takes place around the world as well as in this country. So this is a great opportunity for us to get to know each other better. And we all know that when research opportunities come along, when large calls come out from funders, they often have a frustratingly short timescale for submission. And by that stage, it's often a bit too late to actually work out who's doing what and who wants to do what across the university. So here we're trying to be a bit proactive and to provide the opportunity for us to get to know each other and to develop potential research ideas. This series, as you'll have recognized, is in 3 different meetings. And this is the second of the seminars. The first was looking at the health impacts of climate change, in particular in relation to infectious and communicable diseases, in relation to water, in relation to diet and food. Today, we're looking at things through a different lens, which is through the healthcare systems lens. And one side of that is looking at the impacts of climate change on the healthcare system, in particular, for example, in terms of the ways in which heat can impact the most vulnerable when they're in hospitals and care homes, and other impacts of climate change on the operations of the healthcare system, but also how the healthcare system contributes to global warming through its very significant greenhouse gas emissions. And so there's a lot to cover today, but we're taking this healthcare systems perspective today. And then on Wednesday, in the last of these series, Miles Allen will be chairing the session, which is looking more at the climate extremes and the health impacts that might have on people. Now, there's always a lot of overlap in such a complex systems topic. Let's not worry too much about that. We've done as best we can to carve out 3 different thematic lenses on this question of climate and health. But don't worry too much if you're feeling you're overlapping with things we've already discussed or we may be discussing on Wednesday. We've got some great people here to introduce that topic, and then we'll go out into roundtable discussions, breakout groups in the AirMeet function. I should thank Joe for working incredibly hard to put this together, and also Nevin, who's going to be helping with the discussions today as well. And with that, I'll hand over, I think, to Nevin to introduce the people who are orientating us today. So that's not working. So maybe I should hand over to Olivia Bush from the Centre for Sustainable Healthcare, who's going to begin by providing some orientating words in terms of the carbon emissions from the healthcare system. Olivia, thanks very much indeed for joining us, and why don't you get us going on this Monday morning?
Fantastic. Thank you very much, Jim. Thank you for inviting me. It's an honour to be here and to join such an interesting discussion. So many of you will be aware, I think there's a lot now in the news about the impact of the NHS itself on climate change. So obviously, whilst all healthcare staff are working to heal and improve the health of the population in the UK, at the same time, we know that obviously, as you discussed, and we discussed in the last of the series, that the environment and climate change also has a negative impact on health. And so if the NHS is contributing to those to climate change impact, you're actually undermining your efforts to improve the health of the population as well. And we see this in obviously air pollution and flooding, which is very topical in the UK, but obviously broadly more globally, there are bigger problems, and people have been seeing these changes for some time. So if, as healthcare professionals, and I am a medical doctor by background, if we are going to improve and continue to support the health of our population and our patients, then we need to be addressing the climate crisis as well, in the way that we practice. If we look at the emissions from the NHS, that's 4% of the overall emissions in the UK from all the activity in the UK. So that's a big chunk essentially. So what are we doing? So I work at the Centre for Sustainable Healthcare, and this is a charitably run think tank. And I arguably a bit more of a do tank, because we deliver a lot of change as well. It's not just thinking of producing policy. And there are broadly two aspects to our effort. One side is working on green space, and that is green space specifically on NHS sites, and looking to see how that can improve the health of the community, of staff and patients, and also model good practice around land use. So that's one side, and we do have a research arm related to that work as well. And then the other side where I work is to do with clinical practice and education. And our work there focuses around, we've got a couple of core frameworks really. One is the principles of sustainable clinical practice, which lay out some core elements, such as prevention to start with, involvement and relationships with patients, so things like shared decision making, for example, which was very core to my work as a palliative care physician. Lean working, so making sure every step in your pathway counts, and you're reducing waste, not just in terms of plastic, but in terms of time and energy and effort getting there, for example, and also low carbon alternatives to care as well. So, for example, some inhalers, for example, puffer inhalers, you can use different inhalers which have a lower carbon impact, for example. So lots of different examples of these. So that's one of our frameworks, and the other framework is a concept of sustainable value. And the equation that we use will probably look familiar to anyone here who's from a health economics background. But the key element of that is that we're looking at what's called the triple bottom line, which is, if you're looking at any healthcare intervention, obviously you look at the clinical outcomes and the benefit for the population and the individual, but and we're looking at cost as well. How much financially does this cost? What is the balance there? But are we actually considering as well, and we argue that it is important to consider also the environmental impact and quantify that as best we can. You're normally using sort of carbon footprinting as an approach, and also social impacts, looking at inequalities in healthcare, and also building social values. So those would be all elements that we would suggest introducing. So we've got these two frameworks really, and then we approach this through different approaches. One through sort of healthcare education, another way through specialty groups. So at the moment, it is pretty powerful working with groups who have a sort of strong identity. So this comes through the sense of being in a specialty. So at the moment, I'm working with a group with surgeons in the UK. So we're building a movement for sustainable or green surgery at the moment, and we've got a large event on the 4th of November, co-hosted by the Royal College of Surgeons, showcasing 5 teams that have actually made green surgery happen in their practice, and using that to inspire others. So that's another way that we do it. And then the last way is another area that I lead on, which is looking at organisations and cultural change. And all these areas are going to be really important in terms of spreading and scaling, which I think is one of the key areas which is a challenge at the moment. So there's lots of activity that's been happening in pockets, but the question is, how do we actually spread and scale this and embed it into the usual working of the NHS? So spreading and scaling and cultural change is going to be a key area where it will be important to have partners in sort of carrying out sort of research to check that the approaches that we're using are powerful and really are making the changes that we want. I said the other big area in terms of a research gap is really around carbon footprinting. So there's a couple of areas there which around sort of health technology assessment, so devices that come out and are available. If we're thinking about procuring those, are we thinking about the environmental impact as well? So that is a big gap at the moment. There is interest in filling, but there is a gap there. And then carbon footprinting per se. So for examples, we just have lots of gaps in terms of not knowing what the impacts are. So that might be due to medical devices, it might be due to medicines, which is an interesting element at the moment. There's a lack of understanding, a lack of data essentially around is one drug greener than the other, or that have one got a lower carbon footprint. So those are some core areas. And then one of the last areas that I think is is key is, once you've got all this data, how do you make decisions? How do you balance these up? Clinicians are very used to balancing up, the what's best for the patient, what's most clinically effective, what will fit their lifestyle, and sometimes cost as well. Sometimes that decision's already been made by other bodies, but we're not so used to thinking about factoring in the environmental impact and weighing that up with the other factors. So that's something which we're being asked to work on with commissioners in particular, and I think that will need to be happening to a higher level, also having conversations with the National Institute for Clinical Excellence, NICE, as well. So those are some key areas really. So just talking about obviously where we work in green space and clinical, we've got a couple of key frameworks, the principles of sustainable healthcare and the concept of sustainable value. And key areas that there are gaps are around spreading and scaling and cultural change, and thinking about the carbon footprinting of different elements, which leads through into really thinking about how we make decisions. We're also expanding our work into low and middle income countries as well, because we're very much aware from some of our research. So, for example, a project carried out in India that, in fact, people in low and middle income countries are often used to working with much more constrained resources than we are here in the UK. And have some fantastic ways of delivering very efficient care. And actually, we've got a lot to learn from their practice, and we have learned, for example, in the area of cataract surgery is a key example. So we're looking to start engaging more with clinicians and managers and healthcare professionals in those areas. So I will hand over to I'll hand back to Jim. Thank you very much, and I look forward to meeting some of you in a breakout room and discussing this more and how we can work together to make sustainable healthcare happen. Thank you.
That's great. Thanks very much indeed, Olivia. Let me just see whether Nevin.
Hello, can you hear me?
Oh, we can.
Great. Fantastic.
Excellent. All right.
Very good.
I had to log out and log in. All right. Thank you very much. The next speaker is Anand Yani. He is a research fellow in the Department of Primary Healthcare Sciences at the University of Oxford. Anand has a PhD in immunology from Yale University. He is interested in understanding how we can improve population health through social prescriptions and by addressing social determinism of health. Given the negative impact of severe heat on morbidity and mortality, he sees access to cooling, both passive and active, as a social determinant of health and cooling as a potential healthcare intervention. In this capacity, he works with Oxford Martin School program on the future of cooling. Anand?
Thanks very much, Nevin. Right. So as Nevin mentioned, we're interested in looking at the impact of severe heat in particular on healthcare systems. And currently what we're looking at is the morbidity impacts of severe heat. This quote is from 2018, where we saw that the heat wave increased pressure on services for the English NHS. And in 2019, 20% of all deaths were attributable to extreme temperature caused, and 20% were actually caused by high temperatures. And though we have decent information on severe heat-related mortality, there's still three key unknowns for most healthcare systems. Number one, the morbidity impacts. Number two, healthcare service utilization. And then number three, a follow-on to that is the healthcare costs. And through the Oxford Martin School Future of Cooling program, we're using healthcare data from CPRD, which is a well-established primary care data set. And we're analyzing the healthcare service utilization of over 20 million UK patients to explore the morbidity impacts, the healthcare service utilization, and the healthcare costs as well. And this will be probably, from our understanding of the literature, the first time this sort of systematic analysis of the costs, the direct costs of climate change, in particular severe heat, have actually been analyzed. And we want to use this to inform policy and practice on effective care pathways. And one of the framings that we're taking right now is that if we can expect, and from the IPCC report, the recent IPCC report, I think this is probably sound, hotter summers and more extreme temperatures, at least with regards to heat, then what we might end up in the NHS is sort of a bimodal set of pressures on the NHS. We already have the winter pressures every year, and we now may have summer pressures as well. So that's what we're currently looking at. And in the future, what we'd like to explore is cooling as an actual healthcare intervention. So as Nevin was mentioning, should cooling be seen as a social determinant of health? County councils already provide subsidies for individuals experiencing fuel poverty during the winter time so that they can warm their homes. And there's also programs for folks in lower income statuses or lower socioeconomic statuses to actually have their homes insulated during the winter time. And this is, again, subsidized. Should we be seeing cooling as this same sort of healthcare intervention if temperatures continue increasing? And for us, what we look at is when we're talking about cooling, we want to look specifically at sustainable cooling. So addressing some of the points that Olivia mentioned before about the impact of healthcare services on global greenhouse gas emissions, we would not want to just rely on AC writ large, air conditioning. We want to try to qualify that and find the most efficient and effective air conditioning units or cooling strategies, ideally passive, but active as well if needed, to actually ameliorate some of the severe heat-related morbidity and mortality impacts on citizens. And when we're talking about air conditioning, the key thing we'd probably focus on is ensuring that we're not using the high global warming potential F-gases in the air conditioning units. And just for reference, the high GWP F-gases are 26, some of them are 26,000 times more potent than carbon dioxide as a global greenhouse gas. So they are pretty detrimental, and we'd want to ensure that only the low GWP F-gases are being used if we are using active cooling strategies. The other thing to think about is access. Cost could be a huge barrier, particularly to those in resource-poor settings. So if we're just thinking about the English NHS, yes, we have a universal healthcare system, so all of this could be subsidized. But in resource-poor settings, this might be much more difficult. And sometimes the high GWP F-gases are much cheaper in the resource-poor contexts. And you end up with this vicious circle of actually making things worse by using these high GWP F-gases to ameliorate something that's temporary, but then causing long-term damage and climate change, which will then just make severe heat worse, et cetera, et cetera. So for us, in terms of developing and designing these sustainable cooling strategies, we've come up with this framework that we're using in the Future of Cooling program. And this is a diagram that sort of outlines the macro drivers and the levers for change and the stages of cooling. This was published in Nature Sustainability earlier this year. And this is the sort of modality or framework that we want to use when actually looking at creating or designing context-sensitive cooling strategies for individuals facing extreme temperatures, severe heat in resource-poor as well as resource-rich settings. The other thing we'd like to look at are the broader impacts and the mitigation strategies of severe heat, increasing temperatures and cooling on the SDGs, the Sustainable Development Goals more broadly. Again, this is this graph on the right was from our Nature Sustainability paper, where we looked at all of the SDGs, and we were just looking, very simply at the number of articles and then the subset of articles that related to cooling. And you can see that across all SDGs, we see cooling as something that's not as pronounced as it maybe should be, but it is there, and people are addressing it because they do see it as a primary driver of well-being and health. And if we're looking at severe heat, increasing temperature, cooling effects on SDGs, there's multiple things. Jim already mentioned some of them. Drought, water scarcity, food insecurity, displacement migration, which could lead to conflict, labor, livelihoods. So one of the groups that we're working with, they work with farmers in Vietnam. And one of the kind of sad things is that the farmers in Vietnam can no longer farm during the daytime because it's too hot. So they have to farm at night when the temperature is a little bit cooler. And if any of you have seen the Lancet Health and Climate Countdown that was recently published, it's updated on a yearly basis. They also talked about the number of hours lost to severe heat, particularly for people who have to work outside in fields. And when we're thinking about this, and Jake can't join us today, but this is something that he and I were sort of discussing and ideating about. So I'll kind of very briefly bring in some of Jake's ideas here because I think they're very sound, is looking at the short, medium, and long-term impacts of climate extremes on healthcare systems. So we have the short-term things, which are looking at summer pressures, but then you also have the medium to long-term effects, particularly if it leads to chronic conditions or an exacerbation of chronic conditions. If we step away from severe heat, we have flooding and these sorts of weather events that can lead to PTSD and long-term trauma. And we saw this with Hurricane Katrina, and in Germany recently over the summer, where a few hundred people actually passed away because of the floods. So the long-term impacts are also something that we need to look at. In terms of solutions, they're wide-ranging. But they need to be context sensitive. So looking at conservation agriculture, for example, improving soil health, which can cool the ground by about 20 degrees Fahrenheit and keep things cool, and also improve water tables, tree planting, and passive and vernacular approaches to cooling as well. So this is just sort of a broad, very whistle-stop tour of the sorts of stuff that we're looking at in the Future of Cooling program, and we look forward to discussions and ideating and hopefully putting in some strong bids.
Okay, thank you, Anand. Now we're going to introduce Professor Mike English. He just joined us. Mike English is a professor of international child health at the University of Oxford in Center for Tropical Medicine and Global Health Research and a senior research fellow of the Camry Wellcome Trust Research Program. Mike is a UK-trained pediatrician who works in Kenya for over 20 years, supported by a series of Wellcome Fellowships. He often takes child and newborn health as a focus, but increasingly tackles health services or wider health system issues. Mike frequently provides advice to the Kenyan government and the World Health Organization on a range of issues related to child and newborn survival and health system performance. Mike?
Good morning, everybody. Nice to meet everybody, and apologies I had to join late. As many of you will have probably been trying to escape other meetings. So it's just a pleasure to meet everybody virtually. I don't have slides, and really I think I think the idea was me to just give a couple of minutes about the areas that may be of interest, but I should say that we have minimal expertise. And I can see some of one or two of my Kenyan colleagues may be on this call, so they may want to add further insight. I think what we deal with in general is extraordinarily weak health systems, full stop. For those people who are not that familiar with low middle income country environments, COVID has really emphasized how weak those systems are in terms of actually having extremely poor surveillance. We actually don't understand in most places how much disease and what type of disease there is. So it's very hard to know what is going on and what the impacts might be outside very specific, often quite small settings. So in general, there is a major problem of information. So for example, in Kenya, which is now a low middle income country, if you were to ask the question, how many acute myocardial infarctions have there been in a year? The answer would be we have absolutely no idea. So whether they're getting more or less, we really don't know. So there are problems with information, there are problems with service delivery and scale of services. I think everybody is aware that there's a massive global health workforce shortage, which is actually much more pronounced in low-income countries than it is in high-income countries. So as we compete for health workers, that the same that is happening between countries is happening within countries. So health workers will migrate to places within a country where they are best remunerated and most comfortable. And obviously that puts a huge challenge on how do you provide health services in more rural or remote areas, which are likely to be the same ones that are worst affected by climate change and all its consequences. There are massive problems with infrastructure. So I'm not sure that I've ever been to a Kenyan government health facility which has air conditioning, for example, no matter what location it's in. So if we're talking about increase in heating, that could have profound impacts. It's already very uncomfortable to work in those settings, which I've got some experience of. It potentially becomes more uncomfortable for both the staff and therefore obviously the actual and the patients. So there's huge problems with infrastructure. And one of the challenges for many low middle income countries is that they're supposed to be building their health systems for the future. So in theory, they should be in an active phase of investing because they are under-resourced at present. And if they are going to achieve other global health goals or sustainable development goals, such as universal coverage, then they actually need to be building their infrastructure for health. And so in one sense, there's a huge opportunity to start embedding appropriate principles now, both as a way to make sure these facilities are resilient, but also so that the people who are expected to work in them will consider staying in them. I think we can talk a great deal, I suspect, on multiple aspects of health systems, but key to all of this, to be honest, is financing. At the moment, again, the COVID pandemic has highlighted this. Most of these health systems are obviously completely inadequately financed, and there doesn't seem to be a particularly long-term solution to that. So these countries have always had problems getting basic resources. Their ability to pre-purchased COVID vaccines is an indication of how weak their health and security financing is. And that is just another burden that these countries are having to face as they try and develop stronger health systems. So I mean, we could go on and on, but essentially the challenges are essentially very broad, very numerous, very deep, and climate change and its consequences are yet another one, but the emphasis at the moment is highly likely to be on much shorter term issues, because, yeah, as in many countries, we tend to operate in a sort of for the crisis that's in front of us rather than the crisis that's 10, 20 years ahead of us. So I'd be interested to have discussions with colleagues on this call about what people's ideas are. But I'd also like to make clear that it would be very important in any of these discussions to begin engaging with people in the countries that many of us have worked in, because we don't speak for them. So anything that people are proposing does need to be, people need to rapidly identify who their potential interested partners are in countries overseas, and how anything that's being proposed from Oxford is useful to them and beneficial to them, not just an effort to get a new shiny centre in Oxford. But let me stop there. Over.
Thank you. I think now, Jim, perhaps do you want to say a few words, or should we just lead people into the breakout room, because we are approaching our time for the breakout room discussions at 9:45?
Well, thanks very much indeed for those three introductory and orientation statements. I think that actually sets the scene really well in terms of some of the challenges facing healthcare systems in the context of a changing climate, both in this country and around the world, and some of the responsibilities upon healthcare systems, in particular in advanced economies and countries like this one, where they are consuming large proportions of resources and responsible for greenhouse gas emissions. So I think that was three excellent introductions. It set us off really well. So let's break out, and if Neven, you could explain the different groups we're going into and how that's going to proceed, that would be great. All
right, thank you, Jim. So Olivia Bush will lead discussion on carbon emission from healthcare systems, while Mike English will lead the discussion on large-scale change in healthcare systems, and Anand Yani will lead the discussion on increasing temperature health and healthcare systems, all within the context of a changing climate. We are missing a speaker for climate impacts of health infrastructure and delivery, but this topic can be covered in many different ways in these three breakout rooms. All right, so let's go. And of course, you don't have to just stay in one room. You have opportunity, if you have such an interest, to move from room to room. All right.
Can I please add that the whole point is to meet people, talk to them. You don't have to be an expert. No one's expected to be an expert. So just come and share what your interest is in some of these breakout room themes, and meet some other people. And I'll end this session, and we'll just pick a table and we'll see you there.